Welcome to our presentation on the early identification of barriers to student success in clinical education, utilization of a Week 1 clinical survey tool. Healthcare academic programs include significant components of off-site clinical training conducted under the mentorship and supervision of clinical instructors and preceptors who are not typically employed by the academic institution. Success during these prolonged clinical education experiences depends on many factors well beyond the student's academic abilities. Students are placed both nationally and internationally in Doctor of Physical Therapy academic programs, taking them away from the direct support of their professors and their peers. Assessing the quality of these off-site clinical education facilities and staff falls on the clinical education team in the Doctor of Physical Therapy education programs. We are guided by our accreditation agency to use a variety of interventions to assess quality of both the clinical support staff who serve as clinical instructors, the environment at the location, equipment available, and other factors that all are intended to lead to success during these clinical education experiences. Additionally, we are charged to assess performance of our students while they're away for these prolonged clinical experiences. Clinical education teams typically conduct midpoint conference calls, either in person or through video conferencing around the midpoint of each clinical experience. However, based on the duration of full-time clinical experiences, these midpoint calls or conferences can occur weeks after the beginning of the clinical assignment. Students with perceived concerns related to safety or barriers to learning may not have their concerns identified by the academic faculty until several weeks after the onset of the clinical. Multiple barriers to learning in clinical education have been identified, whether perceived or actual. Common themes include personal safety concerns, professional ethics, inadequate orientation, inappropriate supervision, and poor communication. Research demonstrates that today's healthcare graduate students are under greater levels of stress than their peers. Even before COVID-19, healthcare professional students reported higher level of stress than their academic peers. Fear of failure can compound with the sense of isolation and the level of difficulty at being placed far away from family and friends. Perceptions of safety are often related to clearly identified concerns of high trends of sexual harassment impacting today's students. Research shows us that 53% of female graduate students have experienced at least one incident of inappropriate sexual behavior from an instructor, and that 38% of medical residents suffer from sexual harassment during their training period. Ethical concerns and levels of supervision can often be addressed if identified early by the academic faculty. Students may not have a clear understanding of legal and ethical practice at each state or location where they are located. Students' expectations for supervision can be compounded by communication barriers, hesitancy to ask for more supervision or for less supervision, as there is often not an equal bidirectional communication style employed at the clinics. Students still operate off of somewhat of a hierarchical sense where they are not in a position to openly ask for changes in their communication style from their clinical instructor or preceptor. Based on past trends and identified concerns, The purpose of our study was to explore the perceptions of Doctor of Physical Therapy students related to personal safety and barriers to success in full-time clinical experiences, utilizing a survey tool completed at the end of the first week of the clinical experience. This would allow early detection and intervention as appropriate for these identified areas of concern by our students. Our secondary aim was to examine the reported experiences and findings between cohorts and at the level they are performing in clinical education. Our methods included assessing all currently engaged students in full-time clinical education in the Campbell University Doctor of Physical Therapy program. Students were required to complete a week 1 safety check via an electronic survey. A simple Qualtrics device was used to assess students' perception of safety, how they were communicating with their clinical instructors, the benefit and appropriateness of orientation, and then open-ended questions to gather information on challenges or other concerns impacting students' performance. The frequency and descriptive data were tabulated and assessed using a Mann-Whitney U-test. Both qualitative and quantitative assessment of responses was conducted. Questions of great importance to the Director of Clinical Education were included in these open-ended questions to gather insight on where students had perceptions of barriers to conducting their clinical education in an effective and efficient manner. Our results were such that most students indicated a high satisfaction with their clinical instructor. We found several trends, including that students in terminal experiences rated their clinical instructors slightly lower than students in their first full-time clinical experience. This was supported by an additional data comparison demonstrating that students in their terminal clinical rated their clinical instructor lower than that of their initial clinical instructor. Inferences from these findings have been made in our discussion component of our study. Other areas assessed in the Week 1 clinical survey tool included perceptions of safety. Of the 112 responses, we found 2 students who indicated that they felt unsafe at a clinical site. Upon further investigation, one student cited concerns related to a very different environment than her norm, transitioning from a very rural area to a very urban area, although no safety concerns were reported related to her clinic location, her patients, or her clinical activities. The second student who reported a safety concern reported that the response was completed in error. Thus, the response was removed from assessment. We did find that there was no difference between cohorts for perception of safety or completion of orientation, but there were differences related to how they rated, again, the experience. 4 open-ended questions were utilized to gather information on students' perception of safety, the clinical environment, and other factors that would be of importance to the Director of Clinical Education to ensure that students had a positive start to their clinical. What we found were that students reported CI characteristics as being responsible for their level of satisfaction with their clinical instructor, whether these attributes were positive or negative. Characteristics identified by our students included teaching style and communication style. And then also we noted that students had attributes related to the knowledge that they felt of their CI or their academic level. Personal attributes of the student, such as their confidence level, did not appear to have a significant impact on their satisfaction with their CI. Clinical environment factors that impacted students' perception of safety or satisfaction or barriers to learning included comments related to the number of patients seen, the documentation system utilized, efficiency, scheduling, and the complexity of time management as they moved into a full-time clinical experience. We noted that there were no significant differences between cohorts or levels of the progression of full-time clinical education experiences in the academic program. However, there were differences in the impact of each identified theme and subcategory. Our study has strengthened our desire to provide early intervention and assessment of student satisfaction and performance in full-time clinical experiences. We recognize the importance of early remediation or intervention when communication barriers or performance barriers are impacting clinical success. Simple survey tools can be modified for a variety of applications. Our current tool was actually modified this past year to add safety perception related to COVID precautions in the clinics. Specifically, by early identification of barriers to success, we can employ early advising for stress management, offer additional support systems, give strategies for effective communication based on personality types or levels of experience or confidence of our students, and we can provide objective information when questions occur related to legal or ethical issues that have been identified by students. Assessing our data demonstrates that students clearly have a change in their perception of their clinical instructor and perhaps change in the expectations of their clinical instructor as they progress from their early full-time clinical to their terminal full-time clinical experience. This demonstrates a need for us to better educate our students on appropriate expectations in the clinic and how to improve their own communication styles to ensure that they are dually responsible in their clinical activities for seeking out additional responsibilities or challenges to improve their outcomes.